Okay, hello everyone. I'm Oli Williams and I'd like to welcome you to the latest Bristol University Press webinar where we're asking who lives matter and who dies, and considering what the pandemic has taught us about health inequalities. Our speakers today are Clare Bambra, Kat Smith, Adrian and Terri Gibbons, who have all published books with Policy Press in recent months that address issues that are fundamental to answering the sobering question that we've asked ourselves today. I'm also a researcher of health inequalities, and I've been reading these books in the last fortnight. The greatest compliment I can give the authors and these books is to tell you that reading them is a bit like rubbernecking a car crash on the motorway. It's difficult to sit comfortably with the inequality and the injustice that they detail and unpack, but at the same time, I found myself unable to take my eyes away from the page and the books. I'm very much looking forward to hearing about what the authors can tell us today about their books and about the projects that have informed these books. And firstly, I would like to introduce Clare Bambra, who is a professor of public health at Newcastle University with extensive expertise on health inequalities and especially how they play out in the UK. And Kat Smith, who is a professor of public health policy at the University of Strathclyde, with a long-standing interest in understanding how public policies impact on health inequalities. Their book, The Unequal Pandemic, which I'll give you a snapshot of here, which they co-authored with Julia Lynch, draws on international data and accounts to examine inequalities in the impact of COVID-19. So I'll pass over to Clare and Kat now.
Good afternoon, everyone, and thank you for joining us to discuss the big issues for health inequalities that the COVID-19 pandemic has exposed, and as we'll see this afternoon, unfortunately, has also exacerbated. I'm going to be talking with my colleague, Professor Kat Smith, about our new Bristol Press book, which is The Unequal Pandemic, COVID and Health Inequalities, which we co-authored with Professor Julia Lynch, who's from University of Pennsylvania in the US. We're going to talk through some of the key themes of the book, talking initially about the epidemiologies showing the inequalities in COVID-19. Then going to reflect a little bit about what we could have learned from past pandemics, including the 1918 Spanish flu pandemic. We'll then talk about the central concept of the book, which is that COVID-19 is a syndemic pandemic, an interaction of inequality and infectious disease. My colleague, Professor Smith, will then talk about inequalities that emerge through the process of the control measures such as lockdown, and also try to conclude with some more reasons to be hopeful in terms of how we build a more equal post-pandemic world. So a lot of international data has shown big inequalities in mortality and morbidity related to COVID-19. Data from the US, Scandinavia, and the Global South, as well as, of course, from the UK. And here is some of the British data. For example, the chart here is showing that the 30% most deprived local authorities had mortality rates more than double that of the most affluent. And we can see, for example, in somewhere like Scotland, that around 86 per 100,000 people died from COVID-19 in the first year of the pandemic in the most deprived areas, compared to less than 40 per 100,000 in the most affluent neighbourhoods. There are also big regional inequalities in COVID-19 deaths, and these maps from the Northern Health Science Alliance project show how there's a big spread between the North and the South and the inequalities there in terms of the pandemic. And we can also see that in addition to measures of deprivation, there's something else going on with areas of the North that are more deprived having higher COVID-19 death rates than equally deprived areas in the south of England, again playing on long-standing regional inequalities. Data from the Office for National Statistics has also shown individual level inequalities here identified in terms of people's occupational class. And you can see that for both men and women in England and Wales, the mortality rates were much higher for people in lower occupational groups than in more professional and managerial occupational groups. And perhaps what the pandemic has most revealed to policymakers and the public health community more widely is the extent of ethnic inequalities in health. And we can see here in this table from Public Health England, the really significant and very stark inequalities in terms of the death rate from COVID-19 between white British groups and all other ethnic groups. Now, looking back into past pandemics, we can see evidence, for example, from 1918, historical data shows us from diverse places, including Norway, Sweden, USA, and England and Wales, that over 100 years ago, in the last truly global pandemic, there was also significant parallel inequalities with a higher incidence and mortality amongst the working classes, unemployed and lower occupational groups from the influenza pandemic, and a rural-urban divide as well in England and Wales, which we again see reflected today. Just to reflect on one parallel, we can see, for example, here in some recent work included in our new book, The Unequal Pandemic, Regional Inequalities in 1918. You can see there on the map on the right how the North and the Midlands and areas of North Wales particularly had much higher rates than the more rural areas of southern England. And just to put it into context, the table shows that the areas of the country with the highest death rates up in the northeast of England in 1918 had a mortality rate of almost 1,200 per 100,000, whereas areas in the south with the lowest rates were less than 200 per 100,000. Thankfully, the death rate per 100,000 today is significantly lower than in 1918, but the inequalities remain. In our book, we argue that how we can explain these inequalities in COVID-19, we need to think of the concept of a syndemic and apply it over to COVID-19 pandemic. The concept of a syndemic comes from the anthropologist and clinician Merrill Singer, who worked in the 1990s looking at urban health issues in the US. And he argued that instead of thinking of HIV, drug use and violence as separate epidemics, they need to be thought of as interacting and mutually reinforcing. And this is what he called a syndemic. We can apply this across and think about it in terms of inequalities in COVID-19, where we've argued that we need to think of it as a syndemic, an interaction of existing inequalities in the social and political and economic determinants of health, combined with clinical risk factors as a result of these, which have then reinforced an unequal impact of a new emergent infectious disease. And we can think of that in terms of 4 pathways whereby COVID-19, this syndemic interaction of inequality, has led to health inequalities. The first one is around increased vulnerability, where, for example, more deprived communities have a higher burden of existing clinical risk factors, which in turn are related to their long-term unequal exposure to harmful social determinants of health, such as housing or childhood experiences. The second pathway is increased susceptibility. So thinking about how immune systems can be weakened by long-term exposures to the same adverse living and environmental conditions. So how long-term exposure, for example, to poor quality housing can have an impact on people's respiratory health, which makes it harder for them to fight off a severe case of COVID-19. The third pathway is around increased exposure. And this is thinking about inequalities in working conditions. Perhaps the 2 most stark examples of this are when the lockdown occurs, how managerial and professional groups find it much easier to continue working from home and therefore have very low exposure to the virus. And secondly, whether people are able to self-isolate if they are infected in terms of the sickness pay support that they get from their employer. And of course, for example, in the UK, sickness pay is the lowest in Europe, making it very difficult for people in low income jobs to be able to self-isolate if they need to. And the fourth pathway is around increased transmission. So this is thinking about inequalities in housing conditions and the general neighbourhood. So if a member of the family or household is infected, it's much harder to self-isolate if you live in a smaller house or in a more urban area than it is if you're living in a large house with a low number of residents in a more leafy suburb. I'll now hand over to my colleague, Professor Catherine Smith, to talk about the second section of our book. Thank you.
Great, thanks, Claire. Okay, does that look okay to everyone? You can see, yeah, great. Okay, so I'm going to focus in on the kind of the broader inequalities implications of what we've seen during the pandemic. So we start chapter 3 of the book with this quotation from John Muir, a Scottish kind of environmentalist. He says, when we try to pick out anything by itself, we find it hitched to everything else in the universe. And that is exactly what you see when you look at the research evidence around inequalities. And in COVID-19, you see a range of intersecting inequalities, as Claire's talked about, and then a range of shadow pandemics emerging as a result of that. So precisely those groups who've been most affected directly by COVID-19 have also been most indirectly affected on the whole. So if we think about, for example, people who've had to continue to go out to work, some of whom have had to work in very risky environments. So we think about hospital cleaners, bus drivers, teachers, people working in retail environments and so on, who and care home assistants, many of whom weren't given protective gear for long periods of the initial pandemic period. We can see obviously that they have more exposure, but then there's the kind of consequences of that for them and their families. And I'm going to hone in, because I'm a qualitative researcher, so I always find myself drawn to like individual stories as a good way of reflecting the kind of some of the complexities of what's going on. So I'm going to start with Karen's story. So Karen is a hospital cleaner working in the UK, and her story has been documented for the BBC News website by a doctor working at the hospital called John Wright. And so this is just one of many kind of sources of evidence we feature in the book. So Karen was working as a hospital cleaner. When the pandemic struck, she was worried about getting COVID-19. She was worried for a number of reasons. She had her own health issues. Her partner had long-term health conditions. He was working as a hospital porter, and they were both carers for her father-in-law. Because they were on relatively low pay, because her partner had a more serious long-term condition, so they decided that he would stop working, but they couldn't afford for her to stop working too. So she carried on going to work, and she did ultimately get COVID-19. She then tried very hard to pass on to her father-in-law, and he then passed away. Karen herself continues to suffer with long COVID, although has tried to return to work. So you see here, just in Karen's case study, what this one person is carrying is the long-term health consequences, so the direct health consequences of COVID-19, but she's also experiencing guilt and grief mixed in together, mental health consequences of the decisions that she made in very difficult circumstances. And it has, of course, impacted directly and indirectly on her family. So we see that kind of ripple effect coming out from around her. So very difficult decisions that Karen had to make, and many people would have made the same decision, and she is now living with of domestic workers suddenly being told that they didn't have a job to go to anymore, so leaving the urban areas in which they'd gone to live and work to return home to rural villages in which they'd originally come from. What happened there was you had very large groups of people who'd been living in urban areas where there'd been COVID outbreaks, then returning and mixing with other large groups of people. Sometimes the government kind of put on buses and trains, especially for this people, but then grouping them in together in very densely populated train carriages and coaches and returning them to rural areas, obviously acting then as a transmission pathway for COVID-19. And again, with very similar personal kind of stories emerging from that, of people feeling the guilt, the mental health consequences of having been exposed to it yourself and then returned home, and for other people to have caught it. So I have to say, like, writing this chapter was really difficult. There was really difficult material in it. It was hard to read some of these stories and not feel a huge amount of sympathy, and that more should have been done. Additionally, in the collateral damage chapter, we also talk about various shadow pandemics. So a key one that's been highlighted by the UN is the violence against women during COVID-19. Obviously, if you're experiencing domestic violence, gender-based violence, and then a lockdown happens and you're told that you have to stay at home, that's almost the kind of worst the worst situation that could happen for someone in that experience. And in addition to that, what we found when we're looking at the research literature, and there is an emerging research literature on this, there were stories of women talking about trying to reach out for support, but many of the people who'd been offering the support services weren't able to, be in the offices anymore during the lockdown and so on. So support services were also reduced. And they've also been linked to that concerns raised about abuse against children. So there's a graph there in the bottom right hand corner of the screen. That's like a case study from a particular hospital, a group of pediatricians who are dealing with abuse related head trauma in children, and it's showing that there's a massive spike during the pandemic. And this totally reflected what people working on the front line and social work and so on predicted would happen during the pandemic. Obviously, we're putting people under high stress, and some people were putting them in a very high stressful environment in which there's very little space or room to escape. So you have these shadow pandemics erupting. I think we're going to hear much more about those over the next few years. We also want to make the point in the book very strongly that these various intersections of inequalities are not things over which we don't have any control. Policymakers do have choices, and they have choices and they do make decisions which directly impact on these inequalities. As we went into the pandemic, as we document in the book, some countries were in a much better position than others because they had better safety net programs in place, they had better healthcare services, stronger social policies and so on, and other countries were in a less good situation. So there was the situation going in, which is how countries have chosen to develop their welfare states and been able to and so on. But then there were the decisions that were made during the pandemic, and some states have had more of an eye to tackling those inequalities than others. But the recommendations that we make in the book are that if policymakers are serious about tackling inequalities, then they need to expand social safety net programs, so things like sick leave and support for those losing jobs. They need to increase access to affordable, high quality healthcare and childcare, including mental health services. And they need to strengthen social policies that act on these wider social determinants of health. So that includes environmental regulations, which disproportionately affect more disadvantaged communities via things like pollution. And these policies are, of course, shaped by a wider political context. So we also need to think about the politics of what's going on, which is obviously something Claire and Julia have both written a lot about. So we need to think about the balance of economic power that large corporations wield against labour union protections. And we need to think about how our political party systems kind of involve a range of different people and represent those different communities. And we need to have a real eye to things like voter suppression and democratic engagement and so on. So those are the kind of recommendations that we make. But then we end with some reasons to be hopeful. And I think this is really important, because one thing that really struck me when I looked across the different kinds of research that were being done on this wider collateral damage that's occurring in the context of the pandemic was that wherever you looked, whether it was in relation to people studying migration or people studying environmental climate change or people thinking about gender-based violence, everybody was suggesting that this could be a moment for positive progressive change. So if we break that down, that we end the book with 5 reasons to be hopeful. So the pandemic might stimulate progressive economic reforms. And one of the reasons for that is because we're seeing economic policies that I think just 2.5 years ago, people have said were completely impossible. It would be impossible to implement those kinds of economic changes. But we've seen that it is possible. in many contexts. We also, like going into the pandemic, we were very much in this era of post-truth, and there was a sense there was a real crisis in terms of how scientific expertise was perceived. In the UK, we had like senior ministers going on TV saying the public have had enough of experts. But obviously we've had a re-emergence of the importance of more of a recognition of the importance of scientific expertise in the context of the pandemic, and it's possible that will have long-lasting effects. Where public trust in policy declines, and we have seen in multiple contexts it has declined, and the UK is an example of that, Canada's another example, there may be opportunities to rejuvenate democratic engagement and try new approaches for democratic engagement, and there may be a real push for that. We're seeing some evidence of that in deliberative fora and so on. There have also been some really positive environmental impacts, you know, things like air pollution in some settings. And again, those are things that a few years ago, it would have been hard to imagine that we would have these kind of changes and we'd be able to see them. So people working in climate change are clearly hopeful that that may lead to positive change. And then in terms of kind of migration and citizenship, there's quite a lot of research that's talking about the importance of recognizing that something like COVID-19 can't be contained. You can't kind of other populations and expect that if they are living in really difficult, disadvantaged situations, that communicable disease won't then spread out and impact on the wider population. So there's a hope there that would lead to more kind of inclusive policy making. So that's just a quick overview of all of the arguments that we make and things we touch on, and that is our book there. So that's us. Thank you. I'll stop sharing.
Thanks, Claire and Kat. One of the limitations of Zoom is that after people present, there is no way of applauding. That is, so thanks for your contributions. That was really interesting talk. And we'll now move on to the next speaker. So the next speaker is Adrian Bonner. He is an honorary professor in the School of Applied Social Science at the University of Stirling. In the early years of his career, Adrian's research was based on a neuroscience approach to inequalities. This included work on nutrition and alcohol issues in homeless people being supported by the Salvation Army in the UK, Australia, Scandinavia, and the US. He developed an interest in health policy when he was seconded from the University of Kent Centre for Health Services Studies to become director of the Institute for Alcohol Studies, working with the UK and European health alliances in Westminster and Brussels. His book, Local Authorities and the Social Determinants of Health, which you can see here, is an edited collection in which health, social and public policy experts review structural changes in provision and procurement and explore social determinants of health, including intergenerational needs and housing. It's actually part of a three-part series. The first part, as you can see here, is this blue book, which is the social determinants of health. And the third part has just been commissioned by Policy Press and will be titled COVID-19 and Social Determinants of Health, Wicked Issues and Relationalism. So over to you, Adrian.
Thank you. Thanks for the introduction, Oli. As indicated by Claire and Catherine, the inequalities which have been known for many years have been exacerbated at this time of COVID pandemic. The relationships between social conditions and health have been recognized for many years. In the 19th century, these problems were seen from the perspectives of the deserving and undeserving poor and called social evils. Addressing poverty and social evils at that time, a number of social reformers, including Joseph Rowntree, Lord Shaftesbury, Charles Booth, Bernardo and William Booth, no relation of Charles Booth, were engaged in social action and charitable work, influenced by the church and faith-based institutions. These initiatives laid the foundation for what we now call the third sector. William Booth, founder of the Salvation Army from the 1890s, was committed to working with the poor, the destitute, and the submerged tenth. From those early years, the organization, now working in 130 countries, has been significantly involved in providing support for homeless people, many of whom have addiction and mental health issues. Work also includes supporting vulnerable groups such as women and children, particularly those in fear of being abused and trafficked. But this work continues in 2021 in partnership with the UK Home Office and NGOs in this country and other countries. My research, as Oli mentioned, was focused initially on neuropsychology and biochemistry of alcohol addictions in support of these Salvation Army alcohol treatment programs. Great strides have been made in the science of addictions and psychobiology, but clearly other factors are involved in these and other social evils which contribute to social exclusion. Observing the work of the Salvation Army engaging through relationship building with people in homelessness and addiction programs in the UK and other countries, I began to realise that supporting people at the edge of the cliff required a wider understanding of complex physical, mental, social and spiritual needs of those people. So in 2016, I began to plan a book encompassing a wide range of biopsychosocial disciplines and the approaches which might be used in addressing the social exclusion of people. Very happy to meet Clare Bambra, because I met her in Durham about this time, who introduced me to her work on inequalities and also the Dahlgren and Whitehead model of the social determinants of health. She also suggested that Policy Press was a good organisation to work with. So thank you, Clare. I'll show the first slide now, which hopefully will play. So looking at this rainbow model of the social determinants of health, that intrigued me because many of the issues which had been described as social evils would actually be explained by some of those interconnections and interdependencies suggested by the Dahlgren and Whitehead model. And so in putting together this first book in the series, we had a whole series of parts with 3 to 4 chapters in each mapped on to this social determinants health model. We're very pleased that Catherine was able to submit a chapter on alcohol-related harm in part 2, and Clare put in a really important chapter. Clare and her colleagues looked at the geopolitical aspects of austerity and health inequalities. Quite a few other people came from different perspectives, practitioners and academics, and the last chapter there was actually written by Paul Burstow, MP at that time, who was the Minister for Care, who set in motion the Care Act of 2014. So contributions to this book pointed to the cultural changes from the post-war settlement leading to the development of the welfare state in the late 1940s and the development of the National Health Service. These were golden years of expansion of public services and care in the community. In the Thatcher years, the 1970s, the post-war settlement was overturned, and individualism, getting people off benefits into work and promoting privatization of public services was seen as the way forward to economic and social change. By 2017, the aspirations of Tony Blair's Third Way and Cameron's Big Society led to the coalition government promoting localism through the Localism Act of 2011 and the Care Act of 2014, which was reviewed by Paul Burstow. And in his chapter, Paul indicated that certainly at that time, many of these great aspirations were being subverted by the lack of money as we were moving through this period of austerity after the global crisis of 2008. So the next book really was building on from some ideas based around the central importance of local authorities, but recognizing that the purse strings are controlled by central government, with 98 pence in every pound being spent on our behalf in procuring public services. So we've got some interesting things happening through this book, and the contributors to this book come from a whole range of health, local authority leaders, directors of public health, writing at a time which then became a rather sort of stressful time as they began to deal with COVID-19 in the various parts of the UK. So there was rising concern about inequalities in the state of health and social care at this time, underfunding of public health, which had been transferred to the local authorities in 2013, and the mixed success of health and wellbeing boards set up to support the integration of health and social care. All of these indicated quite a severe shrinkage of the public sector. Chapters in this book from council leaders, Director of Public Health and academic commentators reflected on the devolution of localism agendas within England, Wales and Scotland and across the north and south of the UK. Local governance by local authorities was changing at this time. A reliance on the new management business model, approaches to commissioning and procurement relied upon concepts such as best value duty in compulsory competitive tendering. Outsourcing, which was part of the privatisation agenda, outsourcing of public services was seen to be a failure, underpinned by the collapse of Carillion, the large outsourcing company that collapsed in 2018, leaving 420 public service contracts unfinished, affecting 30 councils, a pension scheme of 2.6 billion, 43,000 employees losing their jobs, 19,000 of whom were in the UK. So really there were some bells of discontent with regard to the way in which local authorities were outsourcing. In this book, we've got a number of people, including Richard Smith, who have been promoting the ideas of a relational approach to contracting and commissioning. The culture change required for relational commissioning and relational partnering across the public, private and third sectors required a number of impacts on legal, social and economic values, contributing to increased social value. So social value was an idea coming through this book, and really is one of the hallmarks of what the main themes of this book are saying. There are two principal outcomes from this particular book. One is the identification at various times in the book of wicked issues, a discovery of the word wicked issues. Apparently that's been around in these circles for many years, and also the collaboration of many of the authors here in the formation of the Centre for Partnering. So the Centre for Partnering is actually a network of 5 universities working with local authorities, private sector organisations and professional organisations. And we've made some progress during recent years, which I'll mention at the very end of this thing. But as we move collaboratively to working on the series of books which underpin the thinking and collaborative thought processes for the Centre for Partnering, wicked issues was seen as an important issue which begins to allow us to navigate and understand those social evils which have been there for many, many years, but unsolved. The Centre for Partnering has promoted the concept of relationalism, and although this has a rather complicated literature through the social sciences and the business world, in simple terms, in the Centre for Partnering, we regard this as the development of long-term sustainable partnering of cultures based upon honesty, reciprocity, mutual trust and respect, and based upon creating a knowledge base as we move towards the further development of the centre. So in doing this, we have now got some progress and just been commissioned by Policy to develop the next book in the series, COVID-19, Social Determinants of Health, Wicked Issues and Relationism, based upon those ideas which you can see on the screen. So this book is fairly well developed, and it comes really at a time when we're looking at COVID, the impact of this within the local UK communities, and also international case studies there from South Africa, India and Nepal. And so it's going to be quite an interesting, wide-ranging reach into the way in which relationalism can be seen as a way forward. So keywords emerging through the pandemic include the commissioning of PPE, and we heard something about procurement. So procurement is one of the greatest interests of our centre, and one part of success is the awarding of a £500,000 grant from UKI for the Centre for Partnering Network universities to begin to look at the impact of COVID-19 on procurement and lessons to be learnt from that as we move forward. So really, I think that's as much as I want to say at the moment, because 8 minutes is a very short time to actually cover all those things. I'm sure I must have gone over time. So thank you for your time.
Thank you, Adrian, for that brilliant talk. And yeah, moving on to Terri now to give us our final presentation of today. So Terri Gibbons is a political scientist at McGill University in Montreal and founder of A Brighter Higher Ed. Her book, Radical Empathy, Finding a Path to Bridging Racial Divides, is part memoir, part research, and part guidebook for helping us all learn to practice empathy and create change. So over to you, Terri.
Thanks so much, Oli, and good morning from actually normally in California. I'm actually in Washington State today, but in any case, for me, this issue of health inequalities is both personal and professional, which is really the way my book is written. It talks about my own experiences with issues around race and racial divides, as well as looking at the data and so on. And so, like Catherine, I like to tell stories. And so one of the things that got me started on this path to writing this particular book was the fact that I have many family members who have been impacted by health inequities. So I start off the book talking about the story of my father, who passed away from a heart attack in 2001. So it's literally 20 years ago this month that he passed away. And it was very shocking because he died suddenly. But one of the first things as a researcher that I did was like, well, why? I wanted to know why this happened. He was 73 years old and seemed relatively healthy. And so when I started to look at the data and some of the risk factors for heart attacks, just being an African-American male was a risk factor. Didn't matter how wealthy you were, how much education you had, just the fact that you were an African-American male put you at high risk for a heart attack. And so over the years, as I had several other family members, pass away from things like diabetes and cancer and so on, where they were at higher risk, I began to realize that, these issues of structural, even though I'm a political scientist, these issues of structural racism were impacting us all, and in the ways that healthcare practitioners were interacting with people from different underrepresented minority backgrounds. I had long discussions with friends who were in healthcare about these issues, and I experienced it myself when I was having issues with endometriosis, and doctors, wouldn't believe me that I had endometriosis because it was something they thought Black women didn't get. So I finally found a doctor who I went to, and he said, he was very empathetic person. And, he asked me if, all these other doctors had told me that I couldn't possibly have it. And I said, well, yeah. And he said, well, no, you can't. And he treated me. And luckily I was able to go on and have children and have some pain relief and so on. So it's really been something that I have personally experienced in so many different ways. Each chapter of the book covers different areas of inequalities and structural racism. But I also have, let me talk about the 6 steps to radical empathy, because really this book is not just about saying structural racism exists, it's about what can we do about it. And so like Catherine and Claire, I'm really trying to help people, not just from kind of a broader policy perspective, but from an individual perspective to say, what can I do to help create change? And so the 6 steps to radical empathy are, first, a willingness to be vulnerable. And I model vulnerability all throughout the book. I talk a lot about my own personal experiences, my family experiences that have impacted our lives. And then the next step is becoming grounded in who you are. And that really takes a lot of work to look inside to understand how structural racism is impacting us as individuals. You may not be racist, but we live in a society where, as you can see from the data we've seen, we have outcomes that impact people in the US, particularly African Americans, more than others. So these health disparities, all these other things are coming out of this broader structural discrimination that impacts us all. Next is opening yourself to the experiences of others, which is very important from the empathy perspective, because we have to be willing. I talk about the golden rule, but actually somebody told me I should really call the next step the platinum rule, because the golden rule is where you put yourselves in somebody else's shoes, but the platinum rule is where not only do you put yourself in somebody else's shoes, but you try to treat, and treat others the way you want to be treated. It's about treating others the way that they want to be treated. So, there's it's really trying to understand not just the perspective, but the life experiences of others. So if I had had doctors maybe who had been more empathetic or really trying to understand my experience and move past their own structural biases, then they probably would have recognized that I was having a healthcare issue that didn't matter what my race was. And then fourth is practicing empathy. Empathy is something that has to be practiced. It's not something that necessarily comes naturally to us. And so I have many tips in the book about practicing empathy. And then next is taking action, which is really critical. That's why we call it radical empathy. The radical component is about taking action. And then finally, creating change and building trust. And, in terms of storytelling, one of the things that really hit me during the recent years when we've been talking about health inequalities here in the US was the story of Serena Williams, who, here she is, this amazing tennis star. She has her child, and she couldn't get her own doctors to believe her when she said she was having some issues. She actually had a blood clot that could have caused her to die, basically. And she finally got the doctors to pay attention, and that saved her life. But this issue of Black women and issues around maternal and fetal health was one of the things that struck me. I remember I was driving around Berkeley one day, and the story came on our national public radio station, and they were talking about the fact that regardless of income or education, Black women were more likely to die or experience a pregnancy-related death than white women. And so that really struck me when that story came out, and I started paying more attention. The New York Times came out with a long story about this issue. And so, as I was writing the book, I started looking up some of the data, and Black women are 3 to 4 times more likely to experience a pregnancy-related death than white women. Black women are more likely to experience preventable maternal death compared with white women, and Black women's heightened risk of pregnancy-related death spans income and education levels. So, this is similar to some of the data we've seen around these other issues. And, my book, I was actually writing it, I was nearly finished with it actually when the COVID pandemic started. And then a few months later, of course, we had the George Floyd murder. And so I don't get into it in too much detail in the book, except in the epilogue and the prologue. But obviously, these issues are coming at a time when we're experiencing a pandemic that, as others have already said, is impacting ethnic and racial minorities as well as lower income people disparately. And also that we have had this uprising after the death of George Floyd that has been global. And so I'm also optimistic that we can take the momentum that has been building around these issues to push for more equitable approaches. I mean, there are things that are going to have to change. And the reason I focus on the individual level is because certain things are going to have to change at the individual level. Students who are going to medical school, there's data that shows that if you do a survey of these medical students, 50% believe that Black people experience less pain because they have thicker skin, these horrible stereotypes and so on that even people in medical school believe. So obviously these types of this type of misinformation, stereotypes, beliefs that impact health and everything, for people of underrepresented minorities in particular have to be worked at the individual level, and we all have to be willing to take on the responsibility to create that change. And so, as I mentioned, at the end of every chapter of my book, I talk about actual steps you can take as an individual to create change. And at the end of, I have a book, a chapter in the book on racism and health disparities. And at the end, I talk about the fact that you can try to understand and take action to remedy health disparities, like learning more about health disparities in your own community. That's one of the things I tell people is a lot of this stuff has to start in our local communities, going to your local city councils, learning more about what's going on in the local news, look at the website for your local public health office. You can find and join organizations in your community that are working to address health disparities. For example, the American Heart Association, the Red Cross, American Association of Retired People, American Cancer Society, obviously in the UK has also many organizations that are doing this work. Systemic change can come with policy changes. Find out what your local and state government are doing to address racial health disparities and write to your representatives to ask for change. And then, as I mentioned already, healthcare providers need to become more aware of bias in the way that it impacts their treatment strategies. And so there is a link that here I will post again, that impact, that where you can talk, where healthcare providers in particular can learn about reducing disparities in healthcare. So I will stop there, and I'm happy to take any questions. But again, not only do we have the book, if you go to the website that's already linked here for the book, there's a free reading guide and other free resources that you can use to share with the youth, look at yourself, but also please, I hope people will share with their communities to help create change. And I'm done, thank you.
Thanks, Terri. That was really great. And as I did with the other authors, here's Terri's book, which you can buy from the Policy Press website. And on that point, all of the books that you've heard the panelists talk about today are available to you as attendees for 50% of their normal price if you use the code at the checkout HEALTH50, so HEALTH50. So now we've got time for Q&A with the authors. Please do write your questions in the Q&A section on Zoom. We've got a few now that we can start off with. So one's directly for Catherine, which is there some work or some way to explore the possible effects that long COVID will have in health in a cohort perspective? So I guess the question is coming from the point of view that the book currently is looking at what has happened, and long COVID is one of the things that can go beyond the current situation.
Yeah, and there absolutely is, and there already are some cohort studies that have begun to be published on this issue of long COVID, and we can expect more down the line. And I think it very much is an emerging picture, but it's clear that a substantial portion of people who contract COVID are left with long-term conditions. Not all of those yet have been kind of diagnosed as long COVID formally. It's one of those slightly fuzzy categorizations in health terms, and I know a lot of that work that's gone on has shown that people have struggled sometimes to get a diagnosis because of that kind of lack of clarity. But yeah, there absolutely are. We're already seeing cohort studies, and we will see plenty more, I think. I don't know if Claire wants to add to that.
Yeah, thanks, Kat. And I would obviously add that there is work going on that's, quantitative cohorts, but there are also some studies being funded to capture people's lived experiences as well. Some more qualitative research about what living with that condition and the impact that it's having on people's life, particularly when thinking about things like employment and income and childcare responsibilities. I guess the other thing to say, sort of in keeping with the theme of today about health inequalities, is there are some studies now exploring whether there are inequalities in COVID. So the REACT study led by Imperial has got REACT 2, which has got a long COVID element now added onto it. And I guess, unfortunately, our kind of hypothesis, I think, from this panel would be that given the case rates are unequally shared, then all things then being equal, you would expect there to be inequalities. But of course, we know they're not equal. So you would probably expect there to be an even higher rate amongst people from more disadvantaged backgrounds, for example.
And following on from that question, there's a related question, which is about the knock-on effect of the pandemic on, I suppose, access to services and things like that. So with things like late or misdiagnosis of problems due to other healthcare issues during the pandemic, whether there will be more serious or more fatal cancers as a consequence. So the question is around, do we already have some evidence, or is that evidence being collected, or data being collected about what is the knock-on effect as a consequence of the healthcare services being overwhelmed during the pandemic?
I mean, yes, there are already, but I think what the studies are showing, and they're emerging like across context now in a range of different settings. I've seen studies in Brazil as well as the UK. It's not just about health services being overwhelmed, but it's also about people being cautious to go into a healthcare setting during a pandemic, I think, or feeling like they don't want to contribute to already stressful working situation, or whatever their reasons are. And I think we're still trying to unpack that. It's clear that people haven't been coming forward, and now that we're starting to see evidence of kind of real concerns around what that means in terms of cancer and cardiovascular disease and so on. So yeah, there's multiple studies. I don't know if anyone else wants to come in on that.
Yeah, that there is beginning to be evidence, and you've got a waiting list of 5 million in the UK now for non-urgent care, which is the highest ever. But again, if we think about it from an equity perspective, then we already know, pre-pandemic, that people from more deprived backgrounds, racial and ethnic minorities were less likely to come forward when they had a health problem, or they were likely to delay coming forward to seek support from health services. So when they did get diagnosed, for example, with cancer, it's often at a later stage of the cancer, it's harder to treat. And so that's partly some of the healthcare disparities that Terri was alluding to in her what she was talking about America. Even within a universal healthcare system, unfortunately, there are also some of these issues. So if we think about the impacts, then again, you would anticipate perhaps that the impact of the postponement of a lot of services, certainly during the first wave, would lead to unequal impacts, and that will begin to show through probably fairly soon when we look at mortality from other causes.
There's a question here which I think it would be good to get answers both from Adrian and Terri, because it cuts across both of your presentations. So what do you think the role of faith-based organisations and or third sector organisations? Obviously these organisations often are working more closely in communities at a community level, but they are also obviously nationwide, is in combating what Adrian referred to as wicked issues. So, the complex issues that don't have simple solutions. So both Adrian and Terri, maybe Adrian starts and then we'll go on to Terri's answer. Adrian, you need to unmute.
Clearly, the voluntary sector, the third sector, is very important, as we saw right at the beginning of the pandemic, which caused Boris Johnson to ask Kruger to write the report. So there's a Kruger report indicating that there should be levelling up, not in the traditional sense of north-south, but also levelling up between the third sector and the public sector. And so there's evidence which Kruger is producing, which shows the importance of communities working together, and in our Centre for Partnering terms, providing a relational dividend, which will actually really help to promote community wealth, which is important in community health. And so we're facing what is $1 trillion debt at the moment. There's got to be new resources coming from somewhere, and I think a lot of that resource could come from a greater collaboration and partnership between the third sector, in particular the faith-based organizations, and the public sector. So I could go on about this for some time, but I better give Terri a chance to put her bit in.
Thanks so much, Adrian. And as you can imagine, here in the States, nonprofit organizations, faith-based organizations have played a critical role in getting the word out about healthcare issues, especially when it came to vaccinations for COVID. I actually work with several organizations that we have a lot of, because we don't have universal healthcare, we have a lot of community organizations that actually have health programs. And so a lot of that community health programs have been coming into play in terms of getting people vaccinated, getting COVID testing, making sure, we've had issues with data in low-income communities, getting that data into the broader systems to make sure we're comparing. Because actually, one of the things the state of California did was say that communities couldn't come out of the different rankings in terms of COVID, easing up on all the different factors that were playing on the shutdown until the minority communities were at the same levels. But anyway, third-party organizations have been huge here in the U.S. And particularly around these kind of broader structural issues, that they have difficulty getting access to healthcare, that they have difficulty because they are working more than others. And so faith-based organizations clearly have an important role to play in the broader system of inequalities and how we can hopefully start to work and get those improved.
Could I just add my...
Yes, sorry. Yeah.
Danny Kruger was at lengths to point out the role of faith-based organizations and the origins right back to those social reformers, which I talked about at the beginning, indicating that they were very important, they still are, mainly because of their contact well within the communities, but also their approach tends to be relational, relating with people, working with people where they are and helping to move them on. And to some extent, there are some people who are socially excluded who are much less likely to go into a formal clinical setting than perhaps in a faith-based sort of support center, both in the UK and the US, for instance.
Thank you for that. I also think it's worth bringing attention to what some people are calling the fourth sector, which is communities sort of spontaneously coming together and trying to figure out the solutions to problems that they're facing, which we've seen a lot of during the pandemic. And that brings together lots of different people. Unfortunately, we've come towards the end of our time together, as we're under strict instructions to finish at 5 today, because there's another webinar following this one. So which leads me to say that thank you to all of you for attending this webinar and engaging in discussion about how the pandemic has, or what the pandemic has taught us about health inequalities. And thanks again to all the speakers for both writing these books and for taking the time out to talk to us today. The challenge for all of us now, came through in everyone's presentations, is pushing for the change that we so desperately need now to reduce or address health inequalities. Lastly, I've been asked to tell you that Bristol Policy Press webinars will now be taking a break with the next event happening in September. Please keep an eye on social media for more information coming soon. And also to remind you that if you want to buy any of the books today, for that we're talking about today, you can do so at 50% off by using the code HEALTH50, so HEALTH50 at the checkout on Policy Press's website. The book that I was involved in co-editing, which has been mentioned in the chat, which is called COVID-19 and Co-Production in Health and Social Care Research, Policy and Practice, is available for you to read free of charge by the Policy Press website, so please do check that out. Lots of the issues that were discussed today have been addressed from different perspectives in that book. And then lastly, thanks again for joining us today and engaging with these important issues. Keep coming together. There is strength in unity, and bye-bye.